Hi there, my name is Claire Harkin. I'm a psychology graduate with the University of Derby based in the UK. I'm also an AXYS Helpline volunteer and a trustee for the Klinefelter Syndrome Association. In addition to that, I'm also the mum or a mum to a 5-year-old with KS. And I'll hand over to you, James, for your introduction.
And I'm James Elander. I am Professor of Health Psychology at the University of Derby.
Thank you, James. And today we're going to be talking to you about our research in gender identity among people with Klinefelter syndrome, qualitative evidence to inform proposals for improved clinical care. Just before I get started, I just want to cover a couple of points with regards to terminology and caveats. When we refer to Klinefelter syndrome, it's referring to individuals with the XXY karyotype who develop physical features and symptoms typical of Klinefelter syndrome and identify as male. XXY refers to individuals with the XXY karyotype who either do not have symptoms or do not identify as male. When we talk about gender dysphoria, we're talking about participants perceived or the researchers interpreted as gender dysphoria, who might reflect societal norms and lack of social acceptance. So the present findings should not be overinterpreted in medical or psychiatric terms. The evidence or the research out there states that KS and XXY may present multiple challenges to psychological adjustment and quality of life. As part of our literature review, we reviewed a number of surveys that looked at the well-being and mental health of individuals with KS and XXY. There were 3 questionnaire surveys in particular. The first one indicated that subjective well-being, body image, self-esteem, mental health, social support, and general health were all much poorer amongst the KS and XXY participants than for the general male population. The second survey indicated that there was lower educational attainment, income, physical activity, and both mental and physical quality of life than matched controls. And in the third survey, it was 68.8% of people with KS and XXY reported clinically significant depressive symptoms. We know that there can be psychological aspects of KS and XXY that can affect an individual's quality of life. The research focused here on gender identity, specifically looking at gender incongruence issues. From reviewing the current literature, there is evidence to suggest that there is an increased risk of gender incongruence and gender dysphoria amongst those with KS and XXY. There were a number of case reports that we reviewed as part of the literature review that looked at individuals with KS and XXY and gender dysphoria, gender reassignment, or other issues related to gender incongruence. There was also another study that looked at the prevalence of KS and XXY, that it was higher among transgender individuals than among the general population. We also looked at a few surveys that asked specifically about gender identity and gender dysphoria. One in particular, there was 87 people with KS and XXY, 65% of which felt masculine, 5% felt feminine, 30% felt neither masculine nor feminine. And the second survey, which the previous presenters, Kai and Yap, talked through, 81% people with KS and XXY. There was 92.5% recorded as male on birth certificate, but only 65% identified as male, and only 61.64% enjoyed living as the sex recorded on the birth certificate. The third survey looked at people with KS and XXY, and they had more symptoms of gender dysphoria than a control group of healthy males, but fewer symptoms than a group of male to female transsexuals. However, none of the KS and XXY group had symptom scores indicating diagnosable gender dysphoria. So the quantitative surveys are helpful in indicating prevalence, but they don't provide insights into how people with KS and XXY experience gender incongruence and gender dysphoria. And although case reports, they are helpful, but it's just very specific to individuals. Therefore, qualitative research focusing specifically on this aspect of living with KS and XXY is needed to obtain a better understanding of the experiences of gender identity and gender questioning amongst people with KS and XXY, which is something that this research has aimed to do. Also, with this research, we're looking to help support and implement the recommendations made by the European Academy of Andrology guidelines on Klinefelter syndrome, where it's been recommended that psychosexual and psychiatric issues in all adult patients with KS are considered, that attention is given to the putative existence of gender incongruence in patients with KS, and that people with KS and XXY and gender incongruence should then attend a respective specialist within a multidisciplinary setting, that there's a setup of multidisciplinary centres or structures for care for patients with KS, and improving the transitional care for patients with KS from paediatric to adult endocrinologists and andrologists, and improving knowledge about KS among doctors and society. The current literature indicates that individuals with Klinefelter syndrome and XXY may be at higher risk of gender dysphoria than the general population, and gender incongruence issues need greater recognition and consideration in services for people affected. This study aimed to give systematic insights into experiences of gender incongruence among people with KS and XXY that could inform more effective implementation of recommendations for treatment and contribute to practical guidance for healthcare professionals. The methods used in this study was individual semi-structured interviews that were conducted over a video call. The inclusion criteria required that participants have a confirmed diagnosis of KS and XXY, they're 18 years or older, and able to give informed consent. Participants were recruited via the Klinefelter Syndrome Association, the XXY Project, and KS and XXY Facebook and support groups. The transcripts were then analysed using thematic analysis. We had 11 participants in total that took part, and their gender identity varied from those identifying as male, non-binary, gender fluid, and female. The age ranged between the ages of 31 and 81. And the country of residence were the USA, Canada, Australia, and the UK. The clinical care that was received was a mixture. So some weren't receiving any care, some were through endocrinologists, some through gender identity clinics, and some through multidisciplinary clinics. There were 4 themes that emerged during the thematic analysis: gender identification, gender questioning, gender dysphoria, and experiences of hormone replacement therapy. The first theme, gender identification, described participants' experiences of exploring and negotiating their gender identity. As you can see on the right-hand side of the slide, there are a number of quotes that we've taken from the participants. Participants varied in the gender that they identified with and how certain and content they were with that, but they all described how their perception of their gender contributed to a more general sense of who they were. Some participants described having a strong, stable male gender identity, but also having preferences and behaviours that they attributed to KS and XXY, and which they themselves described as being stereotypically female. The next theme was gender questioning, which described participants' gender uncertainty and was associated with confusion, isolation, and shame, and how fears about other people's reactions caused participants to keep their gender identity a secret. All participants here described uncertainty about their gender identity, including those who identified as male, as well as those who identified as gender fluid. And it was interesting in that many of the participants' experiences seemed to reflect ways that societal norms made it more difficult for them to discuss and explore gender identity questions. And again, you can see on the right-hand side of the slide there a number of quotes from the participants about their experiences. And we have those quotes there continued. A lot of people talked about just that fear about what would happen if they were to talk about the fact that they were even questioning their gender identity. And again, that could be interpreted as what was going on, what is deemed socially acceptable, potentially. The third theme was gender dysphoria, which described participants' experiences and perceptions of symptoms and aspects of gender dysphoria, which led some to seek support at gender identity clinics and some to transition from male to female. The essence of this theme was participants' recognition or perception that how they felt about their body was incongruent with their gender identity. This theme also gave insights into gender dysphoria as experienced or perceived by people with KS and XXY, and how this may be different from that experienced by other people considering transitioning or contacting gender identity clinics. And again, care is needed in the interpretation of the participants' experiences or perceptions of gender dysphoria, because what some participants, and I explained this earlier in the presentation, described, or we as the researchers interpreted as gender dysphoria, might reflect the fact that society did not accept them as they were. So this theme may be more about navigating societal norms as it is about symptoms of a medical condition. And there we have some more quotes from the participants. And it was interesting that those who did seek support from gender identity clinics, for some that was, as it should be, a pleasant experience, a helpful experience. But for others, it was quite an intimidating, quite a scary experience. And for one individual in particular, actually put them off ever going back to a gender identity clinic again. So the fourth theme was experiences of hormone replacement therapy. And participants sort of talked about needing to have more discussion and counselling before testosterone replacement therapy, and how some benefited from treatment with hormones other than purely testosterone. In this theme, participants described how medical professionals tended to assume that they wanted to become more masculine. And for some, that was, of course, a desired and a positive effect of treatment with testosterone. But for others, that masculizing effect of testosterone had a negative impact on their gender identity and well-being, and especially for those who were secretly at the time experiencing gender dysphoria symptoms, this was quite distressing. There was also that assumption made by medical professionals who recommended or prescribed testosterone. It might have actually, we think, potentially reflected societal norms, or that they might have reflected a medicalized approach in which reduced testosterone was perceived as a symptom for which the obvious treatment was testosterone replacement therapy. And again, people talked about the impact of testosterone, where for some, again, it was, desired effects, and for others, quite distressing. Okay. And also some of the participants talked about their experiences of taking estrogen and how that made them feel. And also a desire to potentially try estrogen, but not being given that opportunity. There was one participant in particular, David, who had asked to try estrogen instead of the testosterone, but was told that in order to do that, they would need to go and see or be seen at a gender identity clinic. And that was based in the UK. So the findings of this research, they give insights into gender identity journeys of people with KS and XXY, from those early attempts to understand and make sense of gender, through to dealing with social pressures, the development of gender identities more congruent with feelings, and experiences of hormone replacement therapy. These findings support 10 specific proposals to promote more consistent implementation of published recommendations for care of KS and XXY. And at this point, I shall hand over to Professor James Elander to go into the detail of what those proposals are. Thank you, James.
That's great. Thank you very much, Claire. And Claire mentioned earlier in the presentation the recommendations in the guidelines of the European Academy of Andrology for adult care for people with Klinefelter syndrome. And we looked at those and felt that our findings support these 10 more specific ways in which those recommendations could be implemented. And the first 3 of those are about promoting more open discussion and support during clinical consultation and care, about including gender identity issues in all patient information and education materials to promote greater recognition and give people more chance to have their experiences explored. And also to schedule discussions about gender identity in a more routine, regular way within consultations during clinical and other care. Possibly as part of the transition from pediatric to adult care, or at the first opportunity, the first appropriate opportunity in adult care. And also about developing materials, for example, case studies. And we felt that some of our research material might be translated into case studies, and we might do further research to generate case studies that would help with the discussion and exploration of these issues. Our proposal number 4 is about the transition from pediatric to adult care, and we've suggested that it could be scheduled as a routine standard topic as part of that part of that transition. And then our proposals 5 and 6 are about testosterone therapy, and we'd like to propose that before testosterone therapy begins, there should be exploration of potential gender identity issues, and people should have a chance to get some counselling if it looks as if they would benefit from it before they start on testosterone replacement therapy. And also, if testosterone therapy or testosterone replacement therapy is being considered, estrogen therapy should be considered at the same time as a potential alternative to testosterone. Our proposals numbers 7 and 8 are about providing specialist services for gender identity issues as an alternative to referring people out to separate gender identity clinics. And firstly, that proposing that specialist services should be more available within Klinefelter syndrome and regular clinics where people with Klinefelter syndrome are seen, so that they don't have to be referred out to separate clinics in order to access specialist gender identity services. And proposal 8 is about providing training for endocrinologists and andrologists and staff working in Klinefelter syndrome clinics, so that they can provide better care around gender dysphoria and gender incongruence issues. And our proposals 9 and 10 are about knowledge and awareness of health professionals. And we want to propose that there's an improved profile and coverage of gender identity issues in standard medical training and continued professional development for a range of health professionals. And also that a better training and educational materials. I mentioned case studies earlier, but including those and other kinds of guidance and support for healthcare professionals to enable them to provide more sensitive and better care around this issue. So there are 10 specific proposals that we'd like to make that we think would enable the kind of clinical care recommendations that have already been published, enable those recommendations to be implemented more consistently and more effectively. Well, as Claire and I discuss what we'd like to do next, and also talk with other people about the next steps in this program, these are some thoughts. I think as expert bodies are considering future clinical guidelines and care guidelines and making recommendations for treatment and care, we'd like to get our findings and related findings on the table so that they're considered and can be part of improving care for Klinefelter syndrome. And also, as we think about the next steps in research, there are a few areas where we think carefully designed studies can make a useful contribution to knowledge. One of those is to look more closely at the experiences of specific groups within the Klinefelter syndrome community. For example, people who are transitioning, people also with strong, stable gender identities to understand that better, and also people in different countries, especially those that are less tolerant of people who are intersex. It'd also be useful to do longitudinal studies looking at change over time in people's gender identity and get a better understanding of what the key change processes are and what the key influences are on change. And as care improves and new procedures and protocols are introduced to improve standards of care and improve the experiences of people with Klinefelter syndrome, it'll be needed to evaluate those and conduct some trials so that we can see what the impact is. It would also be useful to do some studies of healthcare professionals' attitudes, knowledge, and perceptions so that we can see where the gaps are, where the strengths are, and how the knowledge and beliefs of healthcare professionals might be influencing the experiences of our patients and people with Klinefelter syndrome more generally. Well, the next couple of slides are just show the references that we've cited during the presentation. And so I just need to show you the last slide and say thank you very much for listening.
Thank you.